All right, Ed, feel free to take it away whenever you'd like.
All right, folks. Well, welcome back. I hope you all had a great break. Can you hear me okay, Frank?
Coming through clear.
Okay, great. First of all, I have to say, boy, what a way to start off this conference with the four great panelists from the last session. I think it's always important to hear from individuals who have been impacted by hepatitis B and TB in these conferences, and they did a terrific job. And just so you know, we've got three great panelists for this next session. My name's Ed Zurowesti. I'm a family physician. I'm the founding medical director of the Migrant Clinicians Network. I'm also a founding member and board member of Stop TB USA, and Stop TB USA acts as the content experts for the TB Elimination Alliance. I'm also a TB medical consultant for the Pennsylvania Department of Health and the attending physician at 8 county TB clinics. This session will focus on increasing screening, testing, and integration of TB and hepatitis B. We'll explore promising practices that have worked well in the hepatitis B and TB space to reduce patient stigma around hepatitis B and TB in our communities. Each presentation is going to be 10 to 12 minutes, and they're going to be given back to back. And following that, I'll moderate a facilitated question and answer, and then we'll take questions from the audience. We ask those who are attending to please drop their questions in the chat box, and then staff will be fielding them throughout the panel. I'm now going to introduce all three of our presenters, and then they're going to present in the following order. The first presenter is Fatima Amarafilo. She's a patient navigator at the Montefiore Medical Center, which is part of the University Hospital for Albert Einstein College of Medicine in the Bronx, New York City. Following Fatima, we'll have Naomi Louie, who's the Senior Program Manager overseeing chronic and infectious disease prevention programs at the Asian Health Coalition and Center for Asian Health Equity at the University of Chicago. And finally, Dr. Amy Tang, who is a primary care internist and Director of Immigrant Health at Northeast Medical Services, NEMS, in the San Francisco Bay Area, where she oversees NEMS hepatitis B and tuberculosis elimination programs. So without further ado, Fatima, will you please start your presentation?
Hello, everyone. My name is Fatima. I'm going to share my screen. Okay. Can you see my screen, please? Hello?
We can see it.
Yes, we can.
Yes.
Okay. Again, my name is Fatima Omarfilo. I'm a patient navigator from Montefiore Einstein Starfish Program, here to present to you hepatitis B vaccination in West African community in the Bronx. Okay. Why is this not moving? Okay.
Fatima, maybe if you just hit the start slideshow up at the top there. Can you see at the top of your screen? Start down a little bit. Start slideshow. If you come down, actually close to your screen.
Why can't I find it? Oh my gosh. Okay, anyways,
Right
below download.
Right there. Oh, just a little bit further down. I'm sorry.
I don't know what happened.
Right. Oh.
Right above Montefiore Einstein.
It's not coming up on my end. It's not coming on my end, so let me just go. Okay, hepatitis B in the Bronx, West African community. Hepatitis B is endemic in West Africa. Screening and vaccination rates are low. and persists following immigration to the USA. The West African immigrant population in the Bronx is rapidly increasing almost every day. It took me back, oh my gosh. Okay, challenges with hepatitis B vaccination. Vaccination programs in immigrant communities are frequently challenging. Low adherence rates have been attributed to multiple factors that include lack of access to care, uninsured and underinsured individuals, lack of integration into the US healthcare system, poor understanding of the disease process, that means hepatitis B, and distrust of the Western health system. Starfish program started this program by educating the community with an outreach program that ran by the healthcare provider of West African origin in coordination with local faith-based organization that organized the program. So educational sessions held after religious services followed by questions and answers as well. Individuals interested in a free hepatitis B screening provided contact information, and on-site testing for hepatitis B surface antigen and surface antibody at Montefiore Hospital is arranged after the session. After I did that, now it's not moving. Oh my God.
Fatima, if you wanted to shoot one of us your slides, we're happy to share it on our end really quickly. We could move. Okay. Do you want us to move over to Naomi's presentation, and you can send us your slides and we can try to get them up and working?
Okay, now it's moving. I don't know what happened that. So free screening was offered starting in 2019. Non-immune individuals tested prior to 2021 were instructed to contact their medical providers or refer to the Department of Health for vaccination. So free hepatitis B vaccination was offered beginning January 2021, and all non-immune individuals. Non-immune individuals tested prior to 2021 were contacted to determine whether vaccination had been performed and was offered if not received. So individuals among the first 500 screened divided into two cohorts. The cohort A screened before vaccination was available, and then the cohort B was screened after vaccinations became available in the Starfish program. So we did ask the IRB approval for assessing questionnaire to the individuals that needed the vaccination. So out of the 500 individuals we tested, 173 among them were non-immune or surface antibody negative. And then 97 was from the cohort A, and then 76 was from the cohort B. And we also had 71 individuals who tested positive for hepatitis B. 93 completed the questionnaire. So with the cohort A, 37 obtained vaccination from their PCP, and then 33 returned when contacted to come back to the Starfish program for their vaccination. 13 people refused vaccination and 12 lost the follow-up, and 2 people died. So 63, that is 88.1% of individuals among the 500 were vaccinated by the Starfish program, and 6 refused in the co-op 2. So questionnaire, 93 individuals completed the questionnaire, and 53 individuals vaccinated by the Starfish program had access to care, yet they did not go to their PCPs, but come to the Starfish program to get their vaccinations. So we chose vaccination through the program due to trust instilled by the West African personnel that made those 53 individuals to come for vaccination with the Starfish program rather than going to their PCP or the employee's health. So what have we learned from this? Vaccination rates of non-immune individuals from high-risk population in an hepatitis B screening program is low when vaccination is not offered by the screening program, and also when it's not done at the same time of the screening. And vaccination rate is extremely high when offered through the program at the time of the screening. Immediately they are contacted, they will come for the vaccination, which will let you get more people to be vaccinated than when it's delayed. So trust rather than insurance status and healthcare integration is the key factor for motivation individuals to obtain vaccination. Thank you very much. Any questions for me?
Okay, Fatima, we're going to hold the questions till the end. Excellent presentation. Sorry you had problems with your slides, but we'll make sure that everyone gets your slides at the end of this. But great presentation. I think we're going to move on now to Naomi. Naomi Louie, go ahead and start your presentation.
Good afternoon. My name is Naomi Louie, and I am the Senior Program Manager overseeing chronic and infectious disease prevention programs at the Asian Health Coalition and Center for Asian Health Equity at the University of Chicago. And today I'm going to share with you 3 main screening strategies that our organization utilizes to increase hepatitis B screening among Asian and African immigrant communities in the Chicagoland area. So first off, I'm going to share with you a little bit about us. So the Asian Health Coalition was established in 1996, and we partnered with the University of Chicago to create the Center for Asian Health Equity. And we work with over 25 different community-based organizations that serve Asian and other immigrant communities of color in order to improve their health and wellness in the community. And so we focused on health prevention and education and making that culturally competent for these communities. And then in working with these community-based organizations, we provide technical assistance and do various trainings in order to increase their capacity and sustainability to provide the health education for their communities. And then of course, we also do work at the research side and ensuring that these communities get representation in research, and so that our data is out there and able to be used by other researchers. So first, a little bit about Illinois before I get into screening. On the left-hand side, you can see a map here of where foreign-born Asians and Africans reside in the state of Illinois. Each dot represents one individual. So the red for foreign-born Asians, green for foreign-born Africans. And based on the 2020 census, we saw that almost 550,000 individuals are foreign-born Asians in the state of Illinois, and 63,000 are foreign-born Africans. And those are significant portions of the population. And then just in the data that we've collected on hepatitis B among these communities, we saw that approximately 68% don't know their hepatitis B status, who are foreign-born Asians, and then 17% reported being fully vaccinated. And by fully vaccinated, we mean that they've finished the 2 or 3 dose series. And then among the foreign-born African population, we have 72% that don't know their hepatitis B status, and then 26% that are fully vaccinated. And so there's still a lot of work to be done. And we do that through 2 major programs. And so here's a flow chart of basically how we have organized our programs. At the left-hand side, we have community-based organizations really focusing in on engaging the community in hepatitis B outreach and education. And then from that, we move into the screening for hepatitis B, and after receiving their results and knowing their status from the hepatitis B screening, moving forward into care based on that. So for folks who are susceptible, getting referred for vaccination, folks who are surface antigen positive, getting referred to a primary care provider, and then going from there for medical evaluations. We have two major programs. First is the Don't Let Hep B Win campaign. We're in our 9th year now of this campaign, where we work with community organizations to provide that outreach, education, and screening. And then the Better Health program we had for the past 3 years. It just ended in June of 2022, where we worked with providers and clinics to provide screening, education for providers about high-risk populations, and then navigating folks through the through their medical care if they're surface antigen positive through patient navigators. And both of these programs are funded by the Gilead Foundation, Illinois Department of Public Health, and the Office of Minority Health. And so our multi-level strategies here and different partnerships with both community organizations and clinics, that all aims to prevent new cases of Hep B and increase identification of individuals with Hep B and navigating those folks through high quality ongoing medical care. And we've served over 10 different Asian and African ethnic communities, and we provide our materials in various languages. So on the right-hand side, you see a copy of one of our outreach flyers that was designed by one of my coworkers, and then the Yoruba translation there as well. And we have these all professionally translated and then reviewed by the organizations that we work with to ensure that the translations are understandable for the community. And through these programs, we've trained over 40 individuals at 14 different community-based organizations. And through a lot of their efforts and materials that we've created, we've reached over 100,000 foreign-born Asians and Africans in the state of Illinois. And we've screened nearly 6,000 individuals through these community organizations and clinics that we've partnered with, identifying 93 surface antigen positive individuals in the last few years. And so I'll talk about 3 different screening strategies that we've utilized. The first is referring community members to primary care. So our community health workers are trained to support community members to locate a clinic that is near them, that accepts whatever that community member's insurance status is, and then considering their language needs and any other factors. And then the CHW will help this community member schedule an appointment and help confirm whatever documentation they'll need to bring with them to their appointment. And then afterwards, we always ask the community health workers follow up with the individual to check if they've actually gone to their appointment. If they did not go to their appointment, then the CHW will ask if that community member wants to reschedule it and then support that community member to do so. And so one of the resources that we've created is a map of different clinics and hospitals within the Chicagoland area. We haven't covered the whole state of Illinois, but Chicagoland area, and including some of the collar counties where our organizations are located. And so the blue dots there are the different clinics that we've identified, and then the red dots are different hospitals that offer fibroscans or ultrasounds to support those who are surface antigen positive and positive for hepatitis B. So when we have a community health worker who finds a clinic or is looking for a clinic for a community member, they'll locate where that community member resides or where they work, where they'll be able to access a clinic nearby, and then click on that clinic to get more information. And so, for example, if I was looking for a clinic in Rogers Park, where a significant portion of our Indian, Pakistani, and Bangladeshi populations reside, I might click on Hamdard Health. And on the left-hand side, you'll see this information here that our team has been able to put together. Whatever we can gather, we'll put here. So we know that this clinic offers Arabic, Bosnian, Hindi, Polish, Punjabi, Spanish, and Urdu translation for patients that might speak that. And so it might be better for participants who do speak those languages to go to a clinic like this one. And then we also note that this clinic serves patients with or without insurance. And so any other information we are able to gather, we'll put here, and then the CHW can see their website, click that link to open that up, or also give them a call to schedule an appointment for the community member. If I was at a clinic, one of our clinic partners, trying to locate a hospital or specialist to provide a fibroscan nearby a patient, or even if I was at a community organization trying to do that for a community member, I can click on a red dot. So say I was in the Chinatown area, for example, I might end up clicking on this particular specialist's office. And in some cases, we're able to create a partnership with a doctor's office or with a clinic where we can identify a specific staff member to help with making appointments. So in this case, at this particular location, we have an individual staff member whose contact information is there, their phone number and their email, where any staff member at a clinic or community organization can contact them directly to schedule an appointment. And it's going to be much faster and easier than actually going through typical processes like contacting them through their website or giving them a call at their office number. And then for folks who don't have insurance, we've also included rates for these services that are related to hepatitis B, and then also have noted that this particular clinic takes insurance, private insurance, and then Medicare and Medicaid. So as much information as we have, we'll include there so that our CBO staff and clinic staff can have everything that they need. And the second part of this strategy we've been piloting is a website called the Illinois Care Continuum. And so our team has been working on developing this site where we can create this community and clinic partnership. So community organizations can directly communicate with a clinic through this website, and it's all HIPAA compliant. And they can directly schedule an appointment for a community member with that clinic. So I might decide to schedule a patient here, provide their information, and then choose an appointment time and schedule them for that time. And then the clinic would confirm that they've received that appointment and will schedule it on whatever EMR they use. So this is currently being piloted. We're still working it out the kinks here, but we're hoping that this direct partnership building will support that appointment making so that folks don't have to wait on a phone line and in order to schedule an appointment for a community member. Our second strategy, which is pretty common, and I'm sure a lot of folks have done before, is community screenings. And so we've done a few community screenings offering free Hep B screening at community organizations, so their actual location, places of worship after their worship services, and then also at a local college, we were able to rent out a large room to hold a screening. And so these have been generally really successful for some of our ethnic communities. And thirdly, during the COVID-19 pandemic, there was about 1.5 years when we were unable to hold a community screening. And so we referred folks to get their free hepatitis B screening at a Quest Diagnostics location. So their patient services centers are located across the Chicagoland area, and we were able to order their tests for them, and then they would get a sheet of paper, kind of like the one on the right-hand side, with their name, appointment date, time, and location. They'll be told to bring their ID to the patient service center and then present that to get their hepatitis B screening. So they'll get that blood draw at the center. And then we would mail them their results afterwards. So you can see the different locations where those centers are on the left-hand side. One of the issues that we came across in doing this was that we have a huge gap here on the south side of Chicago. There aren't really any service centers here for Quest. And so folks that are living in this area, which are a lot of our African immigrant community folks, they live quite far from their nearby, from the nearest Quest location. And so some of our funding went towards transportation reimbursement or Uber gift cards so that they could go to their Quest appointment and then go back home afterwards. And so that worked fairly well for us, and folks were really inclined to use this strategy for screening. And some overall lessons that we've learned. So for Quest, it was really great for our uninsured community members, especially because it was free. This worked really well with our African immigrant community members, particularly with the Haitian community and the Nigerian community. However, the issue that we faced was for folks that needed to be vaccinated or who were surface antigen positive and needed to get connected to a primary care provider, access to regular medical care was still really a big issue. And so we've been trying to work through that and supporting these uninsured folks to either apply for public insurance or otherwise find a place where they can get medical care. And then secondly, because we were mailing out results, it was a little bit tricky because some of the community members were fairly transient. So they would move from place to place. They wouldn't forward their mail, so the mail would get mailed back to us about a month later. And so we had to work with our CHWs to make sure we had phone numbers or emails so that we could email encrypted results to them, or otherwise make sure that they the CHWs had consent to have the patient's information and results so that they could provide it over the phone. And so that was one of the issues. Those are kind of the solutions that we came up with, and we're hoping to continue to work on that. The community organizations hosting events and screenings, we saw a lot of success there. Large events were fairly motivating for certain ethnic communities, such as the Chinese community and the Lao community. They received that social support to get screened just by having a large group of friends or family going to these events. And then lastly, working with community organizations. While we work with several clinics in the Chicagoland area, the community organizations have that bilingual, bicultural background that can really provide that access and language support for community members to get their hepatitis B screening and really motivate them. And so we have one particular CHW who has had her own experience being screened and vaccinated, and having to go through that process herself, and sharing that story with community members that know her well and that respect her, has really encouraged and motivated folks to be screened. And so in terms of applications to TB screening, this is probably the thing that we rely on the most, and we really focus on supporting our community organizations to be able to have that capacity to support community members to get screened and get that extra language support that they need as well. So that is it from me. Thanks so much, everyone, for attending the session and listening. And that's my email there if you want to connect. And of course, I will take questions at the end of all the presentations. Thanks.
All right. Great. Thank you very much, Naomi. That was great. Very mature, long-lasting program you have there. And our final speaker today is Dr. Amy Tang. And so, Amy, take it away.
Good afternoon, everyone. Just want to verify you can see my slides.
Yes.
Yes.
Okay, great. So today I'll be talking about Northeast Medical Services viral hepatitis B, C, and tuberculosis elimination programs with a focus on testing. But just to give an introduction for those who are unfamiliar with NEMS, we are a federally qualified health center in the San Francisco Bay Area. We've been around for about 50 years now, and we serve about 67,000 patients annually. So our patient population is very specific in that we do serve a majority Asian population, about 90%, who are limited English proficient. About 80% of our patients prefer to be served in a language other than English. About 77% of our patients have Medi-Cal, which is California's Medicaid, and that includes 17% who are dual eligible for Medicare as well. We have a 7.5% uninsured population, and about a quarter of our patients are 65 years or older. So I will be presenting mostly from a clinic perspective and the in-reach rather than the outreach that we've been doing. We also do community outreach, but for the sake of time and because other presenters have covered this as well, we'll be focusing on how we have focused our efforts on making sure that our internal patient population has been screened for Hep B and TB. So, one thing about our NEM-specific providers is that there are unique risk-based health screenings that we need to consider for our unique patient population. And so some of the health conditions or diseases that disproportionately affect our Asian immigrant population are hepatitis B and liver cancer, tuberculosis, smoking and lung cancer, H. pylori infections and their relationship with stomach cancer, and other, the list goes on. But really the top two, Hep B and TB, are the focus for today. So some statistics from our internal data, we found that about 1 in 3 of our patients have been infected with Hep B in their lifetime. This is as evidenced by a positive core antibody test. About 1 in 12 of our patients are surface antigen positive. And many of them, when tested at NEMS, are finding out for the first time that they have chronic hepatitis B. We of course know that about 1 in 4 patients in terms of the natural history of Hep B will go on to develop liver complications like liver cancer and cirrhosis if they are unmonitored and untreated. But we also know that 1 in 4 pregnant women in San Francisco receive their prenatal care at Northeast Medical Services. So this is a huge priority for us, in which we've invested a lot of resources. So this is just kind of a roadmap of our viral hepatitis B and C elimination plan. And we have brought C along because it makes a lot of sense to do testing for both. There's already a USPSTF recommendation for testing all adults 18 to 79 for Hep C. So we have the sort of blanket screening, which I'll kind of go over on the next slide, of why we test all adults for B and C. We also vaccinate all of our susceptible patients for hepatitis B. We have a dedicated Hep B moms program, which I will not be talking about today. And then we also have several services like FibroScan Clinic for liver fibrosis staging. We have in-house ultrasounds for liver cancer surveillance and community health worker program to keep patients engaged and linked to care. So a little bit of data about some of these health disparities at NEMS. For diabetes and hypertension, which are probably the most common chronic conditions nationally, we actually have a little bit less than the national average, and even less for hypertension than the national average. But for chronic hepatitis B and TB, we have an outsized proportion of patients affected. So we have about 8% of our adults affected with chronic Hep B, and that's compared to 0.3% for the US average. And if you look at those with core positivity, it's 36% compared to 4.3%. For latent TB infection, about 20+% of our patients have a positive TB test compared to 4.7 for the US average. So these are disproportionately affecting our patient population, and that's why we have dedicated elimination programs. In 2020, we made the decision to recommend that all of our adult patients get screened for hepatitis B and not just risk-based, which was recommended and is still recommended by the United States Preventative Services Task Force. Because 90% of our patients are Asian, 80% are non-US born, and we have an 8% positivity, we decided that we would just have a blanket testing recommendation for our organization, for our patients. And, you know, even if they were low risk, there's still opportunities to vaccinate, and knowing that only about 1/4 of the US population, of the adult population, has been vaccinated for hepatitis B. So we found that there was really only benefit in issuing a blanket recommendation, and that it would also easily match the current Hep C recommendation. So you can see that we built in this EHR clinical reminder to test adults ages 18 to 79 for hepatitis B and C if they haven't had a test already. So our hepatitis B screening, this is data as of a couple months ago. About 80% of our patients who have been seen for what we call like a UDS encounter. So just an encounter, it could have just been seeing our dental department or, you know, accessing NEMS services in some way. 80% of our adults have been screened at least with the surface antigen during their time at NEMS. And 47% of those who have been screened, or 47% of our adult population has been screened with the full triple panel, which includes the surface antigen, the surface antibody, and the core antibody. So around 2020, we also designed a Hep B screening panel so we could standardize the way that providers were testing for Hep B. I think in the past, there were providers who were really only using the surface antigen and the surface antibody, but we felt like it was important to also check core status, because that can also determine prior infection and risk for reactivation in the future. So our, you can see here that over the years, our proportion of patients who have received the full screening panel have increased. And just a note about hepatitis C, our hepatitis C screening has also increased over the years, and I think will continue to increase. and about 46% of our population has been screened, and this is something we're actively working on as well. Now on to tuberculosis. NEMS has actually committed a lot of resources to improve TB testing and treatment over the years. So particularly since 2010, when we started our EHR and having an electronic annual TB risk assessment, and various changes we've made with our EHR and having provider education, working with the local health department. So with all of these different efforts that all these different efforts throughout the year, we have been able, throughout the decade, we have been able to increase TB testing in both our adult and pediatric populations. So you can see here, at least for adults, it started off as only 6% of our adult population screened for TB. And this is with either an IGRA or tuberculin skin test, all the way to 47% of our adult population in 2019. And then for our pediatric patient population, it went from 23% to 80%. And I think some of the school initiatives and recommendations for TB screening probably play a big role in why testing is a lot higher in the pediatric population. You can also see in some of this data that we have also increased our AGRA, so use of quantiferon blood test over tuberculin skin test over the years. If you extrapolated this to 2022, it would actually probably be 80% IGRA at this point. And then I won't be talking too much about treatment, but over the years, we've also increased the proportion of patients prescribed the shorter rifamycin-based regimens, even before the official recommendations. And a lot of this is because of our close collaboration with our local health department and staying updated on the recommendations. So this is a really busy table, but I really just wanted to highlight here that our younger patients, our pediatric population, has had a lot more testing compared to adults. And there's a lot of different factors for this. Our adult medicine providers, I think, have a lot of really competing demands and some very complicated patients who are older in age and polypharmacy issues. And so I think that sometimes it's a little bit more intimidating for our adult patients who serve a lot of senior patients to do the testing, but also the treatment side of things, because I think a lot of people in their medical training are taught you don't test unless there's an intention to treat. And patients with comorbidities and diabetes, hepatitis B, there's often this fear of patients getting liver toxicity on some of the TB regimens. There was also a disparity in testing based off of insurance status. So with Medi-Cal as our reference group, you can see that all the other payer types had lower testing. So the lowest testing was seen in the Medicare only group, because for anyone who's a clinician or working in healthcare, probably familiar that Medicare often declines several of the TB screening codes, and it can be challenging to find out which one works. And so whenever we get a patient who gets a large bill from Quest for a test that wasn't covered in the way that the provider had ordered it, it I think makes providers fearful of ordering the test again for that type of payer. The same thing goes with when I say here other publicly funded, that's like our covered California plans, and then some of the private plans are a little bit less predictable. Fortunately, with the Medi-Cal or Medicaid, we do know that the TB test is covered with the sort of straightforward ICD codes that are used, and a lot, basically, I think they almost cover any code used for a TB test. And then you can, of course, uninsured patients are tested less as well. So this is just a TB care cascade for adults and pediatrics. So you can see that of the non-US born patient population, how many hadn't been tested yet in 2019, how many were tested that year, and then going down the cascade, had an evaluation with a chest x-ray and then treated. It's hard to see as you get a little bit further with the pediatric population because the positivity is so low, but we do see higher treatment rates for pediatrics compared to adults. And I think a lot of that has to do with polypharmacy and multiple chronic conditions. This figure is just to illustrate that there's a lot of provider variation in TB testing and treatment. So we tried to see if there were any trends by specific sites. So NEMS has 12 clinic sites, and we wanted to see if there was any trend in providers at specific sites. And so there was some clustering, but our largest site also had a very big variation in provider practice, even within one site. But you can see that the pediatric providers here are definitely a lot more likely to test, although there's a lot of variation in who's comfortable with treatment. So in order to address some of these testing and treatment disparities, we developed 2 interventions as part of a CDC grant that we're receiving in collaboration with UCSF and the California Department of Health. One is to engage our pharmacists in monitoring and treatment for patients who are on latent TB regimens, and then also to have a standardized way of marking completion of treatment. And the other one, which I'll be elaborating on today, is our TB standing order intervention. And so the TB testing standing order intervention is really to identify all of our patients who haven't had a TB test, who are between 18 and 79 years of age, to notify their PCPs or their primary care providers that we are recommending this test, and we'll be sending an outreach letter to the patient. We give the providers an opportunity to add on any additional labs that they would like the patient to get during this 2-week notification period. And then we refine our list in case there are patients that the providers do not want us to reach out to. We mail the letters to the patients, and then we have community health workers who will follow up with the patients about any positive tests, next steps in the care cascade, making sure they're linked to care if they are not already, and also doing additional outreach for people who haven't gotten their tests yet. So this is just outlining the inclusion and exclusion criteria for this intervention. And we are actually bringing Hep B and C on board with this standing order intervention, in that any patient who has no TB test and they are also missing a baseline Hep B or Hep C test, we are actually having them get the testing all at once. So I think that kind of comes into our theme of integrating Hep B and TB testing together. So when we do different waves of outreach, sometimes we'll focus on people who are only missing the TB test, and then a different cycle we will include people who are missing both the TB and Hep C test, and then also other permutations of that, TB and Hep B test, or all 3. This is a sample letter that we will be sending patients. So this intervention will actually be starting later this week. So it's very fresh, and we probably give you feedback on how it goes in the future. So I am going to stop sharing my slides and then just briefly talk about some of the barriers to some of these interventions. And I think the most notable one, as I kind of already mentioned, is that the TB test is not always covered by some of the ICD codes that we would normally use for ordering a TB screening test for Medicare recipients and some private payers, and that's been a big challenge. Also, for community outreach purposes, we have done, I think, about 5 community outreach events this year since things have started opening up. And we're lucky to have a grant through Quest Diagnostics to cover the cost of QuantiFERON blood tests. However, the cost of that test is much higher than a Hep B screening panel. And so I think that can sometimes be cost prohibitive for organizations who are hoping to do community outreach for both, unless they have grant funding. So NEMS has also been thinking about potentially bringing this QuantiFERON test in-house and doing it in our own lab, and that would help address some of the payer issues that we've been experiencing. We can also create sliding scales for self-pay patients to try to address these disparities that we see by payer types. But I will open up the session to questions so you can also have time to ask the other presenters.
Great. Great. Thanks an awful lot, Amy. 3 great presentations, and it really has a lot of questions. So if the other 2 panelists can, put yourselves on. Good. Welcome. I'm going to start out the questions with, we all know that there's a lot of patient stigma for both the diagnosis of TB and with hepatitis B. And so how have you folks addressed that stigma? And how has it affected the communities and the outreach work that you've been doing? Fatima, why don't we start with you?
Yeah, so basically we've not started adding the tuberculosis to the testing that the Starfish program provides. We were focusing on testing the surface antigen and the surface antibody of individuals that come for testing. So as we were discussing earlier this week about adding the tuberculosis to the test, and as I said before, the stigma to that is something that we need to add to the PowerPoint presentation during the outreach program in order to elaborate a little bit on it before testing people, since it's not part of the presentation that we've been given. So in order for them not to see something new when they come for testing, we need to start adding it to our presentations and educate them about it before we can start actually testing them with it.
Anyone else want to comment on stigma when you're working with hepatitis B or TB, and how you address that with your communities?
Yeah, I can share a little bit. Because we work so much and so closely with community health workers, a lot of just how they talk about it and engage the community and outreach materials around Hep B has made a big difference. And I think having like those stories and like personal experiences that they're willing to share is really helpful. We try to just also emphasize, like, whenever there's changes to like recommendations, making them more broad to like the whole public, and recommending screening and vaccination and coverage for vaccines from different insurances and public insurances. I think that makes a really big difference for people to know, like, okay, it's not just targeting me, it's pretty broad. And so we've seen with those like policy changes, we've actually seen a lot more openness to learning more about Hep B and being screened.
Right.
I think I wanted to add a little bit more on stigma again, in the sense that the community as a whole are scared of confidentiality among the healthcare workers, especially if you are part of them or part of the community they are affiliated with. So we try to make them understand how important confidentiality of their information is. So that also opens more room for them to go for any kind of test that in terms of tuberculosis and other things. So I think confidentiality should be the main focus of the educators, so that they will be more open and comfortable to share all their histories, or become comfortable to come for testing when needed.
Excellent.
Thank you.
Excellent. Amy, do you have any comments on stigma?
Yeah, we have a hepatitis B moms program, and I think where stigma comes out the most is when we try to do household contact screening for the moms. So we often ask about spouse or other household members and their Hep B status. And though I see a lot of chronic Hep B patients in the clinic routinely, I don't think that it comes up a lot unless we start talking about testing individuals that are close to them, either in the family or in the household. And patients have a reluctance to discuss their status with other people, even if it could potentially be life-saving, like to ask their siblings or their family members, and specifically their spouse, if they've been tested, means disclosing their status. And I have seen a lot of reluctance in kind of avoiding that. And unfortunately for our Hep B Moms program, like, we can't push so hard, like we can only make the recommendation and offer free testing at our organization, but there's often just people are just don't really want to take it further than that. I would also say that, you know, being part of our local SF Hep B free, we've also tried to see if any of our patients would be willing to share their stories with others to try to raise awareness and decrease the stigma. And it's been very difficult in our immigrant population, especially those who are limited English proficient, to share their stories. I think that their status alone and their limited English proficiency makes them concerned about sharing their experience with hepatitis B so publicly, and how they would be perceived and how that would affect their status in a lot of different ways. And so unfortunately, I would say that a lot of the public, like patient advocates out there who experience Hep B themselves are often those who are, you know, successful, maybe second generation, or you know, fully integrated. So I think that there's an association there with stigma as well. And then lastly, with tuberculosis is integrated into the immigration sort of process for a lot of immigrants who come here through, I guess, the normal routine screening process. And I think that TB testing and treatment is kind of viewed more as a compulsory process, like they have to do it. And if they're found to be positive, they feel like they have to take treatment in order to stay here. And it's interesting doing TB testing and treatment in the primary care setting, because we are not immigration enforcers. We do testing, we talk to them about the benefits of taking treatment, but they can also opt out of it. We try not to make it's different from, you know, if they had to get treatment in order to come to the perception of having to be treated in order to come here as a public health effort. So I think I'm kind of, you know, I serve a little bit of a population health role in my work, but I'm also a primary care provider and have the patient's best interest in terms of the risk and benefits of treating them with their own health profiles. And it's something that I try to reconcile on a regular basis.
Yeah, all excellent points. And we have a question from someone in the audience. And the question is, for the hepatitis B vaccination initiatives, do any of you presenters have information on the percentage of patients who complete the vaccine series? So we had a lot of statistics about you've screened, you found people who are negative, and you offer vaccines. What percent of the patients actually complete the vaccine series?
Yes, I think I can go with this question in the sense that out of the 173 individuals that we found to be non-immune, only few of them, we have like 97 in the first co-op, as I said before, that actually completed their vaccine, and then 76 in the second co-op. So it was very challenging to detect that when it was 3 shots, in the sense that people come for the first and second shot, and the third shot was a little challenging for people, that you have to call them and remind them to come for it, or some of them will not even come. But when we started giving the 2 doses, it was completely different, that almost all the people that we contacted were able to finish their dose. So that was the differences that I noticed. But we could say maybe 3 or 4 out of the 173 that we found were the only ones that did not complete the shot.
Okay. Naomi, Amy?
Yeah, so when, I think it was 2021, when ACIP had made their recommendation that all adults aged 19 to 59 receive the Hep B vaccination, we decided to do like a letter outreach intervention with our CHWs following up on the letters for our patients who had screened susceptible and had not gotten documented Hep B vaccine. And I think that when we initially started that intervention, about 35% 5% or so of our patients had actually completed vaccine, and about 50% had initiated vaccine. And then after the intervention with the letters and the community health worker outreach, we increased it to about 40% or a little bit over that. So our strategies were to, well, first of all, reach out to those who never finished their vaccine series, but they started it. And then to reach out to patients who were coming in for appointments anyway, but hadn't started their vaccine series. And we found that the uptake was pretty good for patients who were already coming in for visits. It was just a reminder for them to get their vaccine at the time of their visit.
So continuity of care is really important in trying to finish this off, which is always a difficult thing. Naomi, do you have any comments on the percentages or what your experience has been?
Yeah, so we don't follow super closely from the community organization side because of confidentiality. But from the data that we have from the clinics, we just have total like those patients, adult patients who are fully vaccinated overall out of all of their patients. And so it's fairly low. The clinics we work with serve a variety of individuals in the Chicagoland area. But we did see an increase with the ACIP recommendation in 2021 as well. And so for 2022, we landed at about 10% of the patient populations out of the 3 clinics we work directly with that are fully vaccinated, but that is up from 5% back in 2019. So we think it's a really good increase, and hoping to continue working with folks to increase that even more in the next few years.
Yeah, I think this is a very good point, because it's great for us to do all this screening, but what the ultimate goal is that we prevent hepatitis B and prevent TB. And the only way to do that is to make sure that the people that screen negative for Hep B finish up their vaccinations, and people who test positive for TB get treated, and so that their LTBI is treated. And that I see as a real huge challenge for all of us. And so anything that you folks can do as you move forward, because that's really the ultimate outcome that we really want to see. So any information that you folks and best lessons learned, and I know, Amy, you're working on this a lot, the end of that LTBI cascade is really the ultimate outcome that we want to see. And that's the most challenging thing for all of us. But if we don't get there, if we don't prevent hepatitis B and we don't prevent TB infection from going on to active disease, then all our screening efforts really have not come to fruition for us. Any comments on that from any of you? And we're about ready to wrap this session up, but any pearls that you want to throw out at the end here of how we're going to get there?
Well, I think that from a community health center, it's important to educate the providers on follow-up of those identified with, positive hepatitis B or Hep C tests or TB tests. And it's very feasible, I think, for primary care to take this on, but it does require additional provider education, because I don't think all residencies cover this in their training. So places like Northeast Medical Services or Charles B. Wong in New York, I think it makes sense to invest resources to make sure PCPs are as comfortable managing chronic Hep B and treating and testing and treating for tuberculosis as they are managing diabetes and hypertension. It makes sense, but I do see it as a challenge in other more mixed and diverse healthcare settings where you have a lot of low risk patients, but also high risk and many, many more different languages. It can be much more challenging.
All right. Well, I'd like to congratulate all of our 3 panelists. These are amazing stories. And some takeaways that I got from this is Fatima has shown that really, if you want to reach communities, you have to do it with the folks from the community. I think she had a great example of And when you screen people, you have to also open up the vaccines. You have to give the vaccines yourself. She gave a great demonstration of that. And Naomi shows a very mature 9-year program in a very large city that have done tremendous outreach to the community and affected hundreds of, 100,000 people. That's amazing takeaway. And so I encourage you now, Naomi, to look at the TB part in your community. And Amy has shown how a community health center can really do both, and what the barriers are and how difficult it is for primary care to take both of these on, but they can do it successfully because in reality, it's their patients who are going to avoid getting hepatitis B, chronic hepatitis B, and avoid cancer down the line and avoid active tuberculosis. So I think the three of you have really shown some excellent examples of what we can do moving forward. So I want to thank the three of you, and we're going to move on now. We actually, I want to thank you for a really outstanding second session of the first day of this 2022